Hey, it's Sherry McNeil, and I am summarizing my article that we read last week, which was Progression to Severe Hypernatremia in Hospitalized General Medicine Patients, Observational Study of Hospital-Acquired Hypernatremia. Out of 180 patients, the group was divided into two. There were non-progressors and there were progressors. In the progressor group, the factors that were a part of this group were that their serum creatinine level was higher on average, and then they had serum sodium levels 150 millimoles per liter that peaked after day 5. The patients that were progressors were also in an older group, and they also had higher proportions of stage 4 and 5 of kidney disease. Their GFR was less than 30, and they had their serum continued to increase on the onset to moderate hypernatremia. So the non-progressors, they had their peak serum was 150 millimoles per liter, and they did not rise further in the group. It did not rise further in the group. Serum creatinine was significantly abnormal on discharge. The free fluid volume influences concentrations of sodium in millimoles per liter in the body. The study found a higher estimated free water volume of intravenous fluids and severe hypernatremia. Out of 180 patients, 159 of those patients received intravenous fluids before the onset of moderate hypernatremia. So normal saline was the predominant fluid that was given at that time. There were 4 variables associated with hypernatremia, and those variables are age, the volume of free water, increase in serum creatinine, and chronic kidney disease. There are multiple variables in another model, and age was not a significant factor. So in this hospital, 10% of the patients with hypernatremia developed moderate hypernatremia with 150 millimoles per liter, and eventually they moved to severe out of that 10%. The greater volume of free water prescription was associated with progression of severe hypernatremia. Hyponatremia is more common than hypernatremia, and that's in the early stages of chronic kidney disease. But once the kidneys start shutting down further, then it reverses and it becomes hypernatremia progresses. So in the chronic kidney disease stage, that may be a risk factor for both chronic and community-acquired hypernatremia. Hypernatremia is more common when the GFR is below 30, and it's at highest risk and has more significant implications and mortalities when that happens. The inpatient mortality was defined as failure to survive to discharge or transfer. Out of the 180 patients, 52 of those died during their admission. The types of intravenous fluid are concerning. There were high percentages of normal saline that were being prescribed that led to hypernatremia. 40% of the fluids on average consisted of normal saline after serum sodium reached 150 millimoles per liter. The fact of the study, in the main reason, the goal of the study is to monitor fluids to make sure an amount of free water is given. Less sodium should be used for replacement and maintenance fluids to prevent hospital-acquired hypernatremia. So in these patients, there were limitations to the study. Some of the patients were missed due to coding factors during admission, and some of the patients, the collections they were inconsistent, and there were different studies that defined hypernatremia from 150 to 162 millimoles per liter and as high as 170. So further studies are needed in order to to summarize and to actually to review the fluid prescription practices and remain suboptimal. So further studies are needed. But thank you.